Okay, well, good afternoon. Let's go ahead and get started with our weekly virtual town hall. I welcome those that were able to log in, and we'll also record it so people can see this. So a lot has happened since the last time we talked, and I'll try to give you some updates and also have some updates from other people. How do I get this?
Slideshow start.
So hopefully people can see people can see the what is on the slide on the screen right now, and this is the current status of the epidemic. We have over 1 million cases globally, and it's hard to believe that, right? Because 3 months ago we had no cases, and now we have over 1 million cases. We have 54,000 deaths. The U.S. now, again, think about it. January 20th was the first case in the U.S. Even March 1st, we only had 30 cases in the U.S. Now we're at almost 250,000 cases. We're at 24.7% of the global total, and we have 6,000 deaths, which is about 11%. Here in Georgia, we have 5,800 cases, which is 2.1% of the U.S. total, and we have 184 cases in total. The overall mortality in the U.S. is 2.4%. This is a table looking at states with the highest number of cases, the cases per 100,000 population, the deaths per 100,000 population, and the mortality. And you can see that it pretty hovers all over the place. I said U.S. was about 2.4%, and we're a little higher at 3.2%. And obviously, there's a lot of questions. CDC has asked some questions about why is our mortality higher, but you can see Louisiana also has a high mortality, and so does Michigan. Now, we're not at the level of Italy of 10%, but it's something concerning, and we can talk about it a little bit. And one of the issues that this map shows by county where the cases are concentrated in blue and where the deaths are concentrated. And you can see we have a little bit, I mean, New York is there, but we have a bit of what I would call a southern problem. And whether this is because there's higher mortality in the South because of comorbidities that occur in the South, like diabetes, hypertension, obesity, is something to think about, and something that many are pretty interested in. CDC is, in fact, going to be doing a study looking at this, both at Grady and at Emory hospitals. This is the status of the epidemic here in Georgia. And you can see that one of the things that has happened is that we, Emory, and other institutions, Grady, are doing a lot of testing, and the amount of testing happening outside of Georgia Department of Health is quite significant. Georgia Department of Health has only been able to do 400 tests, and I think we'll hear about testing here at Grady. So let me show you some of the Grady dashboards. We're trying to get the information in a way that it's useful for people. And again, I'll welcome feedback on the dashboards later on. But this is one dashboard we're presenting. Here's the total number of PUIs. The total number of PUIs currently in-house, we have 94 in-house. The number of people that have been tested, how many are positive, how many are negative. About 30% of people, about 25% of people we test are positive. Currently in-house, we have 55 COVID confirmed patients, of which 9 are in the ICU, 4 have been deceased. The ED has had 250 visits yesterday. Average for the ED is about 430, so we're way behind there. And there were about 30 admissions, 40 admissions from the ER. As far as our ICUs, our ICU availability is 110 beds. We have 74 filled, and our vent availability is 71 beds, and we have 46 in use, so we have some capacity still. Here's for the COVID positive patients. You can see how many actually have been tested, what their median age is. The average age of patients here is 57, and you can see of people in the ICU, it's a little higher, it's about 60. And again, you can see our increase in cases, but one thing that is different here than for Emory Healthcare, our ICU patients have stayed pretty flat at about 9 to 11, and hopefully that will continue to be the case, but we need to be braced and ready for an increase, and we'll talk about that later on. There's some risk factors for severe disease, like higher mortality, like age greater than 55, lung disease, heart disease, hypertension, diabetes, etc. And this is a very quick look at Grady patients. And these were 86 patients that Dr. Jensen looked at, and you can see the average age of 57. But look about this 86 patients, 30 had diabetes, 20 hypertension. So diabetes is driving a lot of our underlying disease, and it's not surprising that that is the case. So just an update on inanimate, because this came in the literature recently, and we clearly feel that that contamination of surfaces is more and more important in the transmission of this disease. And I think, again, enforcing the importance of hand washing and enforcing the importance of hygiene. I wanted to make everybody aware of IHME data. This is something that is being changed daily, and it's something that people need to follow. And this just gives you, I'm going to try to make sense of the numbers here. IHME predicts that here in Georgia will peak on April 24th, and that by that day we'll need over 10,000 hospital beds, which means we're close to about a 2,000 hospital bed shortage. And ICU beds will need about a peak of 1,500 beds with a shortage of close to 1,000 beds. So again, Emory Healthcare and Grady have developed plans of expanding capacity because this is obviously a concern, as well as ventilators. And the total peak of deaths in Georgia will be on April 25 with 96 deaths occurring that day. But you can see that the total deaths projected in Georgia are over 3,200. And again, this is just sobering and something that this predictions hopefully will not come true, because this will be really, really hard. One of the issues that needs to happen is we need to really scale up testing in the United States. And that's one of the commitments, but I show you this data because this is too important data. While the US is doing a lot more tests than we've ever done, and you can see in red there, an increase in testing to over 100,000 tests per day, the reality is we're way behind in tests per million population. And in order to catch South Korea, which is probably the country that is testing the most per million population, the US will need to do not 100,000, but 1 million tests per week. So we are 10-fold below where we need to be if we really wanted to do a real scale up of testing. So Georgia Department of Public Health is asking Grady to increase its testing, and there's some plans to do that, and hopefully Susan can talk about that. And finally, I want to mention personal protective equipment. We know what it is, N95 goggles, et cetera, but I want to really give a shout out to Georgia Tech, because Georgia Tech delivered some homemade, they have created some face shields, and they delivered 600 face shields to us here at Grady. And we're going to start distributing those for the people that need it, people in the ICU, people who are doing procedures. And I think it's a game changer to have those face shields. So thank you to Susan Margulis and the Georgia Tech group that have brought those face shields to us. I wanted to also mention asymptomatic transmission. CDC now calls it pre-symptomatic transmission. And this MMWR appeared a couple of days ago. And you can see from this MMWR that it appears that this is playing a role in transmission. Maybe 6 to 12% of transmissions are occurring there. And therefore, there's a big push, and probably CDC this week is going to recommend universal masking in the community. And I show this data because you're going to be asked, how good is a mask? Well, this roughly shows you how good is a mask. An N95 mask is about 90% effective. A surgical mask is about 30% effective. A bandana is about 11% effective. And a dust mask is about 6% effective. So in this paper released today from Yale, they calculate that universal masking could reduce infections by about 10%, assuming that in the community, we're going to see people not using N95s or surgical masks, but using bandanas or dust masks. So we need to tell the community, don't use surgical masks, don't use N95, leave those for healthcare, but it's okay to use bandanas or dust masks. That's going to decrease transmission by about 10%. But again, it should not substitute for social distancing and for all the other things we talked about in prevention. I wanted to mention this activity with the National Academy of Medicine. I'm co-chairing a committee that is doing some webinars, and we've done 2 so far in the science of social distancing. They're available at the site, and you can watch the recordings. But this coming week, we're doing a webinar on advances in spread and also advances in treatment. And again, I'll invite you to watch them if you can. They've really been terrific webinars with over 10,000 people watching them. And they're available, they're recorded, and they're going to be available in the National Academy's website. I wanted to remind you that the Major Lance Bottoms issued a shelter in place on March 3rd. And we're really pleased that the governor has done the same. And actually today starts a shelter in place here for the entire state of Georgia. And I think it's a really important move that the governor has taken, and that hopefully will help us flatten the curve. So again, please, recognize our civic leaders for doing the right thing. Social distancing is making a difference. People are staying home. People are decreasing mobility, and we need to continue to encourage that. I want to finally end by reminding you of the Emory COVID checker. If you don't have this, you need to recommend it to people. It's a great way to check on your symptoms and to check whether you should be tested or not. And you'll avoid a lot of phone calls if you give it to your patients and your family and your friends. And a couple of things about what's happening here at Grady in the future. As I said, testing is going to be scaled up, and Wayne can talk about that. We are about to open the remdesivir clinical trial here. As you know, we've gone into universal masking recommendations inside the hospital, and the community is going to go in that direction. And Emory has also started the COVID vaccine trial, and is one of the 2 sites in the country enrolling in that vaccine study. And with that, I'll end, and I'll invite Dr. Lewin now to give us this update. John?
Great, thank you very much, Carlos, and thanks for that great update. So I appreciate the opportunity to talk to our Emory at Grady folks. So first of all, I want to say thank you. The fact that you and your teams are coming every day, taking care of the Grady patients, taking care of our community is really just is fantastic. And understanding, being closer perhaps to the Emory Healthcare side, but I know the same issues, the same passion, the same rising to the call are really critical. And it's clear that together we'll continue improving lives and providing hope for our communities as we sort of battle this challenge together. There is a lot going on at Emory in general, Emory writ large. Carlos already mentioned several of the clinical trials. Obviously, remdesivir is an important one. We're proud to put the first patient who came into Emory Healthcare, EUH, on remdesivir. And we've been enrolling, so it's great that Grady will also now be enrolling as well as we test to see whether this really does hold great promise moving forward. The vaccine trial is another important thing that, again, being done through Emory School of Medicine is really critical. There's a drug, EIDD 2801. It's a drug that was developed in DRIVE, which is an Emory spin-out, Emory University spin-out drug development company. This is a drug that was developed by Dennis Leota and colleagues. And it's an oral antiviral rather, that we're very excited about. It was developed in part under a Department of Defense bioterrorism grant against Venezuelan equine encephalitis virus, which apparently is a virus that had been weaponized during the Cold War and more recently. But it turns out it's got multiple RNA virus antiviral efficacy, including MERS, SARS, and in vitro SARS-CoV-2 or COVID-19 virus. So we're very excited. It's an oral agent. It's under FDA review right now. We signed an agreement with a small drug company that's going to help us take it into clinical 1 phase trials as soon as we get our IND. So we're hoping that will be very, very soon. Many of the basic science labs are retooling, looking at what we can do to find potential drugs against this. High-end Fu, who many of you know has really a world-class high-throughput screening facility, is looking for drugs that will essentially help to nullify the spike proteins on the coronavirus COVID-2. So we're very excited about much of that work that's going on. But one of the things that I recognize is that the faculty across all of our sites, the VA, Grady, Emory Healthcare, and even Children's, really need to be recognized for the fact they're coming in every day and making such a huge difference for our patients. So I want to make sure that I thank all of you who are on this call, but in particular, anyone who is a leader who is on this group, please thank and recognize every one of the people who report to you, because what you're doing truly is heroic. And what I hope is that this weekend coming up, many of us I know are continuing to kind of work. The weekend days aren't much different than the weekdays, but if you do have time, please try to make time for yourself to spend time with family, friends, pets, anything that gives you personal joy and time to recover a bit. This is a marathon. We might be in mile 3 or even mile 4, but there's quite a ways ahead of us. So make sure you take care of yourselves. Make sure that you take care of each other, those of you who are colleagues, those of you who are friends and family, and really help us get through this together, because we will get through this. We'll be able to look in the rearview mirror and see this behind us. But how we rise to this challenge is really going to be defining. And then the last thing I want to mention is flattening the curve. As Carlos mentioned, one of the most important things that we can do is to ensure that everyone who's not providing a critical function, such as being part of the healthcare team or other essential businesses, that they do stay home, that they really do not congregate. I know the governor said, groups up to 10 or no, should be less than 10. Well, I would say 9 is too many. Stay home with your family unit. 2 is a great number for social distancing. But really, the more we can distance from anyone else, the more quickly we can get this under control, the more we can hope to decrease the surge that Carlos showed and to keep down the total numbers of ventilators we need here in the state of Georgia. And while I suspect everyone on the call recognizes it, Carlos has single-handedly made a huge difference in the local, Metro Atlanta, state, and national dialogue when it comes to flattening the curve. And I was delighted that we finally got the governor to do a very courageous thing, because believe me, as much as we were pushing him to call for social distancing and staying sheltering in place, he was getting equal and even more adamant push in the opposite direction. So I think we all do owe a debt of gratitude to the governor for making the right decision, and he's getting a lot of flack from the other side for that. But it was a great thing that he did. And in particular, I want to thank the mayor and our local government, our county commissioners and other local communities for also doing this even earlier. So hopefully we'll start to see the benefit of that within the next week or so. So with that, I'll turn it back over to Carlos, and thank you everyone for a bit of your time, and have a great weekend.
Thank you, John. We appreciate it. We're going to go on now and have a series of updates. So Susan, you want to start talking to us about infection control updates? Susan Ray, can you hear me?
There, I couldn't unmute myself.
Okay.
Well, I think probably the main update, which is sort of infection control, is that we're going to increase our testing a lot. And Dr. Wong will talk about how and the numbers, but that will result in some downstream effects, of course, for infection control, because we're going to be identifying more people that have positive tests.
Susan, can you quickly
yes.
mention an example of what happened at the burn unit? Because I think that's a typical example of the kind of stuff we're going to be seeing.
Right, I don't want to, there were 2 patients admitted yesterday from the same family to the burn unit. And there was a request to test both of them, even though there was no particular, they had typical presentations for people who'd been in a house fire. And of the 2 people, one was burned less badly than the other. And the one who was burned less badly is well enough to go home today, and has a positive test on a screen that was done. The other person who was more severely burned and has inhalation injury and is intubated had a negative test. They're from the same family. They live together in the house. And that just is if we look, we're going to find it, I guess I would say. And the person who had a positive test is asymptomatic except for the burns that they suffered. And that's something we know happens. This is one of the reasons that I recommend universal masking, and one of the reasons that, I think a lot of authorities are recommending that. We don't have data that shows that helps, but it certainly seems to be worth a try. in my opinion. And I'm concerned about how often we have, you know, our healthcare workers spend a lot of time pretty close together because that's what we have to do in the hospital. We're not able to be 6 feet apart to do our work. And I think it's wise to have masks on to try to limit how much we might be shedding virus if we don't realize that we're ill. So for me, that's the main reason for the universal masking, having mostly to do with controlling source, that we might be a source and we don't know it. And we should consider that our patients may be a source and we don't know it. And that's why we need to practice excellent hand hygiene and covering their coughs and wearing a mask when we're in communication, you know, in patient care. That's hard to execute. And we do have a lot of N95 masks, and that's the most common kind of mask that people have access to. But we are working to increase the supply of other masks that might not be as uncomfortable, and stay tuned.
Thank you, Susan. Appreciate it. Dr. Wang.
Okay, I'm going to share screen.
Okay, go for it. Let me stop sharing though. I need to
Okay.
stop sharing first.
Okay.
Now you can share. Okay, there you go.
All right, so today I'm going to talk briefly about lab update, mostly probably more of a public education. One thing that I showed here in the picture is the rack that we normally do as a relatively large capacity. As you can see, it's by the 16 times 3 and then more, so we can do a batch, and then we can also run more tests on each shift. So this is what generally you will have to understand. With a routine test, we are taking about 6 hours, but it's batched, and especially in the morning, maybe we'll do a more run each day. So that's in general. But then the other things about issues for general education is private labs, such as Quest Lab, like we had, is our reference lab. That right now we all know they have a lot of backlog of the testing. So luckily we didn't send much to them. I know Children's Hospital have some issue with them, and that's why this past week, we helped the CHOA for testing, as well as some southern regionals. So that's in our own way of to be able to handle that. Luckily, at least we didn't send a lot to a reference lab because it took at least about one week. And then last week I mentioned about the two platforms we have at Grady. One is the Abbott Molecular M2000, which I showed the picture about batching, and the other one, GenMark. The issue about that, we go live, but the GenMark is still have a limited distribution issue, so it's a supply chain. But I was told hopefully next week we're getting more. That's a good news. The other thing I want to give you an update about some other testing. You probably also hear the approved ones. It's called GeneXpert by Cepheid. That one was like 45 minutes testing, and we have a system here, but at least by now we are not getting the kit. They are also by the national level of distribution. I heard that Emory ER gets some of those. So that's at least if you hear, oh, Emory is doing that, for what we are looking for the option as well. This is what we place the order, but we have to look at the option when they're going to ship to us. And then the other update from last week is that there are a few more FDA EUA approval, total about 25, just for the education purpose. One is, you probably also, I will explain a little more about the 5 minutes testing, ID now, and then we'll talk a little later. And basically, this is the 5 minutes testing. It looks very small, unique. I know President also talked about that. Just for the laboratory testing purpose, let me just show you a quick overview about how the person have to do the testing. You have to do a test 1 step, put in a blue one and a pink, the orange one. Then step 2, open the blue one kit. Step 3, you put your swab. Step 3, you put the box and then close it. And step 4, take it over to the testing vial, the orange one, then you close it. So that takes time. That's okay because the test only takes 5 minutes that, for the positive and 13 or 15 minutes for the negative. The major potential concern, even though right now we're not available for us right now, just to look at here, this is what we have to looking at. Even this system in the market for at least 2 or 3 years, and why there's not many places to use it, especially if you want to look at doctor's office, it's an open system for you to using a swab and to mix it. So some place, if you have to do it, you have to have a very good biosafety cabinet or biosafety practice. So this is the one thing that potentially will be some concern, especially right onto the machine doing the vortex mix with sample and then with the multiple steps, you have to do it for your testing. So at least to give you a just general education about, it sounds like 5 minutes test is good, but in reality, probably still may be good for the field or maybe some office will have a good isolated room or good PPE and something like that. So, and then also there's another news. I know it's a 2 minutes testing for antibody, IgM, which is also on the news. And we also have a pathology conference talk about that, and the field doesn't trust that. As a matter of fact, Wednesday we discussed this, Thursday, that's the news. It basically major news media retract that. So it's not, it's almost like a hoax, and it's not FDA authorized. So that's another thing to take care of, not much 2 minute testing, okay? And then the other thing you have to look at, ID now, which is we may not get it anyway. And then the another ones potentially we're looking at is called QIAGEN, QIAstat, which I happen to have a 2 system here in-house. What this one potentially do is it incorporate SARS-CoV-2 together with a respiratory viral panel. So that will be potentially will be good in limited fashion, especially for ICU patients or certain things. So we placed the order, we'll see how they can distribute, because everything now is in distribution depending on the company or availability. So that's all I can say for the current one. I will end up here with the other night, when I left the parking garage, you can see the big heart from the hotel. Really appreciate the medical staff. Thank you.
Thank you, Wayne. I really appreciate that.
I will end the.
Can you stop sharing?
Screen. Yeah. Let me go back to the.
Thank you. Really appreciate it.
Where is that? Sorry.
Which one do I need? This one.
Yeah.
Okay, so the next person to speak, Matt.
Yeah, thanks. I can give an update as to what is going on in the ED mainly. We have been obviously trying to ramp up our ability to take care of patients as we're expecting the steep part of the curve in terms of arrivals of symptomatic patients and sicker patients to come in the next week to 2 weeks. So we have been working with all of our partners in internal medicine and MICU, as well as our nursing colleagues, to make sure that we are as ready as we can be. Brooks Moore has been working on protocols for dealing with both cardiac arrests and airways, and we've been converting parts of our ED already are hot and warm zones, and we are getting ready to make plans to convert more areas to hot zones as needed, and then have other areas as cold zones. We have been working with infectious disease and lab to spin up ED-directed testing, and that actually went live just a bit ago, where ED docs, if they determine a patient's a PUI, can actually order the tests and then perform the tests and carry them up to lab for more testing. So that's kind of where we're at. I don't know if there are any questions.
We'll get questions to the end. Thank you very much. I really appreciate that, Matt.
No problem.
Annette?
Yes, so thank you, Carlos. You've already sort of described what our ICU bed utilization is currently and our vent utilization. So we know we're not at 100% saturation and we have some capacity. We currently today, if needed, we could manage about 138 patients on a ventilator, and we have more ventilators that have been ordered and we're waiting for those to be delivered. We have, I think Dr. Todd's going to discuss some of this, and Grady leadership has identified areas outside the typical ICUs where we would house patients that are critically ill in the event that we hit saturation. And I'm working with colleagues, surgical colleagues and hospital medicine, general medicine colleagues to make sure that we have a staffing model once we hit saturation and we have ICU patients in different areas of the hospital, making sure we have the appropriate staffing models to manage these patients. So that's the ICU update.
Thank you so much. Really appreciate it. Dr. Todd? Rob, can you hear me? You got another, is he still on? Because he had another meeting.
He's not on.
He's not on. Okay. Denise, Dr. Jameson?
Yes, can you hear me?
Yes.
Great. So I just have a brief update on obstetrics and pregnancy. So even during a pandemic, the babies keep coming. So our labor and delivery unit is busy, and we have lots of pregnant patients and lots of pregnant healthcare workers. So I wanted to just briefly cover 3 areas that I get asked about a lot. Are pregnant women more susceptible to COVID? Are pregnant women more severely affected by COVID? And the third piece is, are there fetal effects to infection with COVID? So the first piece is, are women more susceptible to COVID? And the answer is no. There's no evidence that pregnant women are more susceptible, nor would we expect them to be based on other similar viral infections. The second question is, are pregnant women more likely to have severe disease? And the answer is, we're not entirely sure. So we had some reassuring data from China early on in the pandemic. Now we're starting to get little pieces of information from New York City and other places, and a little piece of information from the CDC, but really not enough information to know yet. And then the third issue is, are there fetal effects? So is it transmitted transplacentally? So is it transmitted in utero or intrapartum prior to birth? And the answer is, we don't know. There have been some suggestive cases based on serology, but we really don't have documented evidence that it can be transmitted from mother to child prior to birth. Are there congenital effects like we saw with Zika infection? Not that we've seen, and again, based on what we know, it would seem very unlikely. Are there any obstetric outcomes? And the answer is probably yes. There seems to be for women who are infected with COVID, they may have increased risk of preterm delivery. And again, that's consistent with what we know about other febrile illnesses in the 3rd trimester. And then the last piece is, when is the biggest risk to the infant? And the answer is right after birth. So right after the birth, the infant can get infected from an infected mom, just like anybody else. And so that's been one of the toughest messages, is what to do about mom and baby after birth, whether to separate them, whether mom can breastfeed, and all of those questions.
Thank you. That's terrific. That's a great update on questions that we could ask all the time. Thank you very much. Dr. Kessler? Nadine, can you hear?
Yep. Can I share some slides, Carlos?
Yeah, let me stop sharing and you can start. Okay? Go for it.
Hold on a second. Wait a minute. Sorry about that.
Do you have them?
Okay.
Otherwise,
Can you see it? Can you see it, Carlos?
no, we can't.
Hold on. Give me one more.
Otherwise, we have them. We can share them for you.
Just give me 1 sec. There we go. Does that work?
Okay, that's working. Okay, we got it.
Okay, so want to give an update this week from Caring Communities for COVID-19 Caregivers. This is an update from 3:15 to 3:31, just to give you a sense. People have asked for my email and phone number on the front of these so that you can have it, so you can contact us when you need it. Let me see. So just to give you an idea, during that time, we've run 37 support groups at Grady. These are groups for staff in various departments. You see those listed here. We're increasingly going into the departments, the MICU, the SICU, the units caring for COVID positive and PUI patients, for our inpatient and for our outpatient staff. We've also, having a hard time getting this to go here. We've also conducted 17 groups through March 31st for Emory University more broadly, for residents in multiple departments. Today we did neurology and pediatrics residents. Tomorrow we're starting with anesthesia residents. For attendings in multiple departments, whole departments, various organizations, med students, small group leaders, and the like. We have 6 tip sheets online. We actually have an agreement now with Emory, Grady, Morehouse, and Shoah to work together to have all 4 logos on our tip sheets, as well as our Caring Community logo, and we're just waiting for everybody to agree on what that's going to look like. But in the meantime, on our psychiatry website, we have tip sheets up for healthcare workers, the general public, domestic violence survivors, parents with kids, people with anxiety problems, and a list of apps with their links that are helpful. And we have more than 10 more tip sheets that are underway and will be launched soon. We have a number of additional services. We're partnering with Dr. Ray and Dr. Hunter and their teams to provide behavioral health follow-up calls to faculty, house staff, and Grady employees who contact the Grady number, the 404-616-4000 line, and are in emotional distress. We have a 24/7 call-in line for medicine residents and Palm Crit fellows. We've been blogging about this and social connecting in the face of physical distancing. And we're really trying to use the word physical distancing instead of social, because I think the notion social distancing is part of what make people so uncomfortable. We want them to physically distance but stay connected. At the IDP, they've offered a variety of virtual breaks on different topics. You can see some of them here. Drs. Farber and Ammirati have done those. We're starting those at the Bryn Health Center, and we're happy to talk about doing them more broadly for Emory at Grady or Grady more generally. Just want to go through a few tips for people to remember related to promoting teamwork, and I think these are really important as we work in the hospital and people are really stressed out. For people really to look out for each other, checking in regularly, formally and informally with team members, really encouraging people to do this at huddle, change of shift, report, and the like. Really being intentional about good communication. Everybody's stressed out. People are short, they're being critical, and being really mindful about that. Fostering community. As Dr. Lewin mentioned, really celebrating our people's contributions, what's been helpful, what's been creative. Requesting support and debriefing from us if you need it. And finally, I want to thank everybody on here who is on the front lines and making a huge difference.
Thank you, Nadine. If you can stop sharing, that'd be great. Okay, good. So we're going to go now to Dr. Lennox. Do you have any updates for us? Closing remarks? Jeff? Is he on?
It's not in the, it's usually on the phone.
Huh?
Oh, someone's on the phone, they're not talking.
Okay, well, it looks like Dr. Lennox is not on. So, this is not advancing. Okay. So I'm gonna go on and show this at the end. As many of you may know, I'm part of the Atlanta Symphony Board, and I've been working a lot with the symphony. I was in working with the musicians and a variety of things, and they asked me what they can do for us and for the people working in healthcare. And they did this beautiful video, and I hope you enjoy it.
Hi, my name is Jen Ching Lin. For the last 32 years, I've been privileged to be a member of the Atlanta Symphony Orchestra. To the healthcare providers at Grady and the CDC, we at the Atlanta Symphony would like to present this socially distant video of the third Brandenburg Concerto by J.S. Bach. Thank you for being on the front lines and saving lives during this pandemic. Please be well and be strong. And hopefully the next time you hear this piece, we can all be in the same room together. 1, 2, 3.
So again,
Bye
that's
for now, but I hope we see you real soon.
so just a token of appreciation for all the work that everybody does from the musicians of the Atlanta Symphony. Some of them have actually done even more, saying they have donated masks to us and they have done many other things. So again, people are really backing you, people are really cheering you and hoping that we get over this and they realize that it is the healthcare workers who are at the front line of this. So you're all being appreciated. And please know and let your teams and let everybody know that that is the case. So we're going to move on now to the question and answer section, and there's a lot of questions here, and we're going to go to the
What?
how do I kill this? How do I change that?
Don't.
How do I get this chat out? So we're going to move to the question and answer session. So I think a couple of questions that are coming up, and I'll try to answer. I'll pass them around to the people I need to answer. Can those that test positive and recover donate plasma? Actually, that's one of the studies that is being done. There's people in the Department of Pathology and at Emory that are actually looking at a protocol to do precisely that. So yes, there is a lot of interest in plasma. There are several protocols for that across the country. Will the Department of Anesthesiology also get some face shields? Yes. We will have face shields to people that needed anesthesia is one of the priorities. And again, if we need more face shield, we can get some more face shields. We're going to get sufficient. As a physician bioethicist in the Center for Ethics at Grady, I wanted you to be aware of the ethics community has been discussing the ethical dimensions of how to best make the most of ethically appropriate clinical decisions. Yes, next week we will have somebody from the ethics committee talk to us about some of the ethical discussions. I think it's really important to get an update from ethics. I think it's a critical component, and I really appreciate the work being done there. So what is the sensitivity of this test? So Dr. Wong, can you tell us about the sensitivity of the different tests that is being done?
Right now, basically they all listed on the limit of detection on each package insert for FDA. And that's all we can tell. But the issue is because of the respiratory sample, so it could be a clinical sensitivity. It may depend on how you collect it and also how you transport and the nature of the specimen type, like whether it's a nasopharyngeal, oropharyngeal, or tracheal aspirate. So overall, that's where you see clinical performance over the time when we start eventually with serology tests available.
Thank you, Dr. Wong. What is Emory doing to help leverage community-based testing? That doesn't seem to be much movement from state and local governments. Well, actually, Emory has set up a community clinic, a sort of drive-through clinic, and there's a lot of interest in doing more of those. So there is a lot of interest in Emory, as you probably heard from the governor, is one of the partners in making that happen. Last week, universal masking was brought up. Is this an official policy at Grady? Many providers and staff are still not wearing masks. I think this message has not been successfully communicated. Susan, can you talk about the policy at Grady about us masking is related?
This morning, the administration agreed to accept some bullet points from me that they will share, that will explain that we have a universal masking policy. I expect that to come out, maybe over the weekend, but probably Monday. So it's true. It's not, everyone's not wearing their masks yet, but that is my recommendation, and they have accepted the recommendation. Has it been implemented? I would say not exactly yet, but it will be.
I think it's going to be really important that we get this implemented and get this expanded. So thank you, Susan, for your work. How many healthcare workers at Grady or Emory have been positive, have been tested? Susan, I mean, roughly, do you know the number?
No, I don't actually, because we haven't married together the results from testing done at our employee health, the Grady Employee Health Clinic, which does serve all the people working at Grady. So when we say Grady Employee Health, that means anyone who's working at Grady Hospital or clinics. That includes people who are employed or paid by Emory, Morehouse, and contractors, in addition to people paid directly by Grady. But there are other people tested at, privately and through Emory in large part, and we don't have those numbers yet.
And again, I want to emphasize to everybody, if you become infected, if you get tested positive, we want to know, and we want to know because we want to offer you the support that you need, the information you need, and everything that is necessary. So please let us know. There's an email to let us know, and please let us know. We want to know, not to get in your life, but actually to help you with life. What do we know anything about the effects of COVID early in pregnancy? Dr. Jamieson, can you tell us again about COVID in early pregnancy?
Sure. Unfortunately, we know even less about women infected in the first and second trimester. Most of what we do know is in the third trimester. So we really need that information.
Yeah, no, I think it's really important. I think it's something that is also going to happen. My niece that lives in Milan says that there's going to be a peak in deliveries in 9 months from now with all the people staying indoors.
Mm-hmm. We do expect it. We do expect that.
A surge in births.
Surge in births.
Yeah. Do we know, is April 24th expected peak for the US or for just Georgia? Well, actually, if you go to the IHMI website, the peak in the US is expected on April 15th to 16th, and Georgia's later because we didn't implement a lot of the things that we needed to implement earlier. Go to the IHMI website. Each state is different depending on what has been done at the state level. Unfortunately, as I tell people, we don't have a national strategy. We have multiple state strategies. Even some states don't have a strategy. And I tell people that we in the United States don't have an epidemic. We have multiple Wuhans, so it's very different. Can the virus be killed with UV light? Susan, UV light?
Actually, I don't know the answer to that. I'm sorry.
Okay.
I'll have to look that up.
Yeah, and
Actually, I think so because people have done, people have done N95 decontamination using the
exactly.
UV light.
There's a protocol from Nebraska decontaminating the face masks, N95s, using UV light. So I guess it works. But again, we're not doing that here. We hopefully right now still have enough N95s that we're actually telling you, use it for about a week or 2 weeks or whatever time is the longest possible, and then throw it away and get a new one. That's what we want to do. We don't want to decontaminate them. How does the transmission timeline today from COVID-19 in the US compare to the typical transmission timeline in seasonal influenza? If different, does it support the possibility of aerosol transmission of COVID-19? Actually, we're pretty certain there's no aerosol transmission of COVID-19. It's very similar to influenza. The difference is that we have a virus that transmits more efficiently than influenza in a population that is naive, it's immunologically naive. So the transmission is very quick and very rapid. And what we're seeing in the United States is this rapid exponential pace. And I want to be real clear because Dr. Fauci said it yesterday in TV, and I'll emphasize this. Unfortunately, the curve in the US is looking like the curve in Italy. We are in for a big, big problem here. And that's why we have to really do something, because otherwise, I really do not want to be Italy. Italy is having, their healthcare system has totally collapsed as a consequence of this. Okay, next question. What is the process of getting tested if you think we have COVID? And what is the turnaround for the results? So can you go over what employees need to do, Susan? How do they get tested, et cetera?
So the phone number to call to access the employee health clinic and evaluation is 404-616-4000. And when you call that phone number, which is operating 24/7, there are nurses who are, there's a team of them, I can't remember how many, it might be 6, who are ready to answer the phone and they know that it's a healthcare worker calling if you call that number, that you're distinguished from just, a community member calling the nurse advice line. They will ask you a series of questions, get information from you about how to get back in touch with you, record all of that, and then it will be 404-616-4000. 4000 is the last 4 digits. If then you'll get a return call the next day from one of the staff at Employee Health. Dr. Hunter has several nurses and nurse practitioners working with her. And based on what that conversation reveals, you will be given advice, and that advice and recommendation might include testing for coronavirus, which is done every afternoon at Grady, Monday through Friday, in a special area right outside, it's in an enclosed area near the emergency room, with VIP parking in the parking deck. And the results will be back generally the next day. So that's how it works.
Okay, so I want to, thank you, Susan. I want to emphasize again, the number to call to get it scheduled is 404-616-4000. I have a question here that says, I was exposed to an unknown patient Monday who had a procedure, and he's developed a cough and is now COVID positive. How long after exposure is test positive? How long should I wait so it's not a false negative? So Susan, you want to mention if somebody gets exposed, you find your patient is positive, when should you get tested?
Well, so we're not testing people just because they were exposed. But we are, so that's not a recommendation at this time. You can call and talk about it if you're worried about the fact that you were exposed. But in general, that's not a reason that we're doing testing.
Correct. So the lesson there is we don't test people just because you've been exposed, okay? Very important. Okay, question here. If it seems that there's a possibility of having a deficit of ventilators is a real possibility. So who will give guidance as to who receive ventilators and who's not? As I mentioned, there is a committee, there's an ethics committee discussing precisely this, and next week we'll have an update from the ethics committee. Are we still at Grady wearing N95 masks indefinitely until they are soiled? How do we know if we lost the seal and should get a new mask? Susan, you want to talk about masking? Your favorite topic?
It is my favorite topic. If your mask looks embarrassing, then you should get a new one. We don't want people looking shabby. And by that, I mean it has blood on it, dirt on it, you know, clearly contaminated with body fluids. So if it's too loose, meaning you cannot make it stay on your face, then that's also a reason to get a new one. You can check for an effective seal by pushing it against your face and then sucking in as hard as you can, which can be pretty hard to do, don't faint, and see if you can make the mask collapse a little bit, and that means that you have a good seal.
And again, in many places, including Emory Healthcare, they're actually using not N95, but surgical masks, and there's reason for that. You know, depends on the availability of masks. Places are doing one or the other. As long as we can have surgical, I mean, N95 masks, I'm okay with that. But if you have a, you know, a procedure mask, that will also be fine. But we don't want to run out of procedure masks because our surgeons need them. So please, you know, continue using N95s as much as you can. Okay, will there be the Saralinubab clinical trial available at Grady? I'm not sure. There are a couple other clinical trials coming. Jeff, are you online? Can you talk about the other clinical trials that you know? Yes, probably Dr. Lennox is getting disconnected. Okay, we'll get an update on clinical trials next. I think next week we'll do an update on clinical trials. That sounds like a good thing to do.
Carlos?
Yeah.
Can I, Marsha Peters, nurse practitioner Marsha Peters, who works with employee health, has given me an important correction.
Okay.
It usually takes 48 hours to get your result back, just taking into account the timing of when we're obtaining the specimens. And they generally are not calling people back on the weekends with their results.
Okay. What are we doing? What should we do for the newborns of mothers with COVID?
Carlos, do you want me to answer that?
Yes, please.
So it really has to be decided on a case-by-case basis because reasonable options include separating mom and baby at birth and then having the mom express her breast milk. And if there are concerns about contamination of the breast milk, discarding the breast milk. Sort of a less severe option is to have a healthy caregiver feed the baby the express breast milk. And then there are some professional groups who would recommend having the mom breastfeed and just have good breast and hand hygiene. So I think it really depends on a case-by-case discussion with the mom and her family about how sick the mom is and other factors. So there's, you know, whether she can control her coughing and sneezing and secretions. So again, I don't think there's one answer.
Okay, thank you. That's great. Any word on antibody testing or effectiveness of plasma therapy? Wayne, you mentioned antibody testing. Can you remind us again? Do you think you'll have antibody testing at Grady soon? So antibody testing is being developed, is being implemented. There's a group in pathology very interested in antibody testing. There's a group in pathology working on antibody testing and also in plasma therapy. Can Hughes Spalding send their test for COVID to Grady lab? Susan, I thought that Choa and Hughes Spalding were doing that, right?
Choa actually is going to be sending their SARS-CoV testing to Grady lab. They're working that out. Is that what the question was?
Yeah. Will test volume increasing? Will results be reported out more than once per day? Yeah, I suspect so. There are 9 ICU patients at Grady and approximately 30 ICU patients at Emory Healthcare Midtown, each of them. What is our thought about what accounts for that difference? I don't know. There's a lot of thoughts don't have any specific thoughts, and it's just interesting. I have no idea. I've talked a lot about this with my wife, who's at Midtown. She thinks it's two things: a higher population of end-stage renal disease patients over there, and also the fact that there is the area around Midtown is a little bit like New York. A lot of people living in high rises and buildings, and that may make a big difference. But really don't know. I think that's a really good question that we're all trying to answer. But it obviously scares us here at Grady because we're so close, and it probably is going to be hitting us at some point, you know? In addition, sensitivity, do you know false negative rate for the test? Again, remember, false negative is depending on many factors, including sampling, including, pre-test probability, et cetera. So it's hard to know what the false negative is. All I can say is a negative test in the right clinical setting should not exclude COVID. That's a really important lesson out of this. A negative test in the right clinical setting should not exclude COVID. Will Grady testing for COVID antibodies? If yes, again, I don't know. We are going to try to do that. What advice should I give family and community members that ask about creating or buying a mask? Well, the advice is, I said before, if they're going to make or buy their own mask, they should wear them. But we don't need cloth, or we don't need homemade masks in the clinical setting. And the same thing, we don't need them to be hoarding N95s and other masks and take them away from us. Are there any real concerns about patients will have a negative nasopharyngeal sample? Should an intubated patient have an aspirate or BAL test sent? Yeah, in an intubated patient, we're preferring that a tracheal aspirate or BAL be sent rather than nasopharyngeal sample. Don't send both, it's not necessary. Can CHOA or Emory clinicians who are working at Hugh Spalding be tested for COVID at the Grady Occupational Health Clinic? Susan? They're Emory employees, right?
Yes. That's the short answer.
Yeah, exactly.
People who have an employee health problem or an occupational health concern who are working at Hugh Spalding do come to see Dr. Hunter or call employee health for Grady.
Okay, for universal masking, are we to take an unused mask home so they can be present in the hospital mask? Right now, I can't mask until I get in my area in the hospital. If you keep your mask inside your plastic bag or your paper bag, it's fine. You can take it home with you and then bring it back.
Yeah, I thought people were taking them home.
That's what we were doing.
But maybe, I'm not sure. Also, for the universal masking, meaning not, that's not for patient care of a patient with COVID-like illness or suspected COVID, but just the universal masking. We will allow cloth masks because we will not be able necessarily to provide enough comfortable surgical masks, and people may prefer to wear a cloth mask instead of an N95 while they're going about their work all day. So that's also going to be in the guidance that comes out.
Will Georgia peak predicted in 3 weeks? Are we assuming there are people that are currently not infected? Yeah, a lot of them are going to be people that are recently infected or not infected yet. And that's why the social distancing may actually help us decrease the peak. What do we know about hospital-acquired COVID? Are we keeping track of those patients? Are we aware of any cases? Yeah, we are aware of a couple cases maybe, and that's being looked at. Is Grady currently reusing N95s that are turned back to Grady? No, they're not, as far as I'm concerned. How do you feel about UV light to disinfect our homes? Again, I think this virus dies with normal cleaning. You don't need something hyper. Any specific precautions to handle storage maternal breast milk in patients, in infants admitted to the NICU? Denise? Are we to leave our personal scrubs at work or change in and off, or should we treat them like regular clothes and bring them home and wash them? Overall, is there any evidence that the virus can live in clothes for several hours? There seems to be mixed messaging. I think there's probably not any evidence that the virus lives in clothes and stays there for several hours. I think taking your clothes home and washing it at home, but if you want to change, you know, in your garage at home, if you want to change here in the hospital and then put regular clothes, I think that's reasonable. But there should not be a problem washing them at home. With loss of jobs and insurance, will Grady continue to see patients even though they do have updated financials? I suspect so, but that's a good question for Grady. But I do worry about that. As you know, a lot of people have lost their jobs. When you lose your jobs, unfortunately, in this country, you lose your insurance. So I suspect the rate of uninsured is going to go up really, really significant. Did I hear you correctly, Dr. Del Rio, say that this disease does not spread via aerosolization? Yes, it doesn't spread through normal aerosolization like TB does, but it does spread by procedures that produce aerosolizations, like, for example, nebulization, intubation are concerned. Susan, you want to add to that?
I think you covered it well.
Okay. Is it not prudent to disinfect and conserve PPE? For the time being, we're not disinfecting PPE because it's actually more complicated. Can employees get tested even if they don't have symptoms? We are not testing asymptomatic individuals, employees at this point in time.
Not at this time.
How can we find small N95s? Martha, I'll get to you directly on that. Small N95s are hard to find. They have been essentially disappeared from the market, but we have a few people that need. We can get a few for you. We don't have that many, but we will talk specifically about that with Dr. Ward. The general stance is that masks are reserved for potential active infections and healthcare workers, but it appears that governing bodies are on the verge of recommending universal masking wearing in public. If that is the case, would Grady provide masks to us to warn outside of healthcare setting? Given the data you presented earlier about asymptomatic spread and significant inability of homemade masks to block the virus, can we use our N95s in public errands? That's a good question. I don't know the answer.
I think it's up to you.
Yeah. Cloth masks have increased risk of transmission. I don't think so, but they're a decreased risk of protection. If pre-symptomatic people can transmit the disease, should we consider testing periodically people at highest risk, i.e. multiple exposures in ICU, ED, others? One tests are widely available, particularly in healthcare workers. Yeah, I think once we have more testing, we're probably going to be testing a lot more healthcare workers. It is a randomized controlled trial that shows 30 times risk of infection with cloth masks versus surgical masks. Yeah, that's the study in influenza, and that's why we don't recommend cloth masks in taking care of patients. It's okay to have in the community, but not to take care of patients.
And yeah, that's a study about acquiring influenza when you're exposed to it, right. Taking care of somebody who has it. The idea of wearing a cloth mask while you're feeling well is that we're trying to limit the emanation of virus from you if you happen to have it. And it is more effective than nothing.
Correct. Okay, well, with that, we'll end. Thank you very much. I appreciate everybody joining, and we'll see you next week. Please have a nice weekend.